Pour ne pas nous mettre en retard, nous avons une matinée assez chargée, comme vous voyez avec le programme. Il y a 4 interventions prévues ce matin, donc je ne voudrais pas prendre trop de temps. Mais quand même, je voudrais d'abord prononcer quelques mots de bienvenue pour Joseph Parnasse. C'est vraiment un grand honneur pour nous de recevoir Joseph Parnasse. Alors, j'évoque quelques dates. J'ai demandé l'autorisation. Joseph Parnasse est né en 1950 et il est né à Lublin, en Pologne. Alors, pour ceux d'entre nous qui ont connu l'époque de rideau de fer, bien sûr, c'était la Pologne communiste. Il a fui en 1968 avec sa famille juive en raison de l'antisémitisme qui sévissait à l'époque. Et puis, il a pu arriver au Danemark et faire une magnifique carrière. Je dois avouer que j'ai un peu honte aujourd'hui parce qu'il me semble qu'on aurait pu inviter Joseph Parnasse plus tôt. On a quand même beaucoup attendu, mais voilà. En tout cas, on essaye de réparer aujourd'hui cette erreur. Et je m'occuperai donc, pour ceux qui ne le connaissent pas, Joseph Parnasse est bien sûr à Copenhague, Danemark. Il est le cofondateur du centre de recherche sur la subjectivité. Nous avons le nom en français, le titre en anglais. Et puis bien sûr, il est psychiatre, professeur de psychiatrie à l'université de Copenhague, etc. Joseph Parnasse a énormément publié des articles tout à fait décisifs sur la schizophrénie. On va avoir l'occasion aujourd'hui d'en parler de petit corpé. Et sans plus tarder, je lui donne la parole pour son intervention.
Merci. Merci. Alors, je veux remercier tous les organisateurs de cette conférence. Je veux d'abord dire que je vais donner ma conférence en anglais, mais je vais prendre la discussion en français et aussi les questions en français. Je suis malvoyant, c'est pour cette raison que j'ai ces lunettes de soleil que je mets parfois parce que je suis très photosensitive. Alors, I'm going to talk about schizophrenia and about the current status of schizophrenia as a medical disease, as what is very frequently said as a disease of the brain. And as you perhaps know, everybody, the situation of psychiatric research today is in a state of a sort of global crisis. Basically, there has been a fantastic progress in the neurosciences, but this progress in the basic neurosciences and the knowledge about the brain, the neurons, the pathways, the neurochemistry, has not translated into practical use in psychiatry. If we look specifically at schizophrenia, basically every brain structure has been examined by different means. Currently, there is a big research in immunology. There has been also research into the intestinal bacteria and stuff like that. And what can be said about empirical research into schizophrenia is that this research has been extremely dictated by technology. That is to say that there are not really any ideas about schizophrenia, but each time we have a new technology that is available, then perhaps 4 months later, you see an article comparing 30 patients with schizophrenia with some 30 controls on this technology of interest. And that's basically the model of psychiatric research today in schizophrenia. The other problem, which is very significant in this respect, is the very definition of schizophrenia. So if you look at the official criteria of the Diagnostic and Statistical Manual of Mental Disorders, schizophrenia is basically not defined. There is nothing written about what is schizophrenia. What is written in the definition are the diagnostic criteria. And the diagnostic criteria comprise a mixture of negative and positive symptoms. So we have this bulk, ontological bulk of negative and positive symptoms, which are defined in a rather high severity level. And there is no consideration of what is basically wrong with patients with schizophrenia. So the idea is also in the treatment of schizophrenia is that if we take a patient with schizophrenia and we remove this ontological bulk of negative and positive symptoms, then there will be a normal person left behind. And this is this type of ideas is behind the most of the pharmacological treatments today. So in this respect, our own research in Copenhagen represents something different, which is also something which is trying to get into the processes of mental causation. When I say mental causation, it should not be understood as a sort of downward causation, but simply the evolution of symptoms on a phenomenological level or on a psychological level. What is characteristic for psychiatric research is that any biological theory of schizophrenia, let's say a theory concerning neurocognitive disorders, is only a beginning of the explanation, and the rest of these typical theories is phrased, is formulated in a sort of common sense psychological manner. So, for instance, disorder of the thalamus leads to inadequate filtering of sensory data, and this leads to mental confusion, thought disorder, and so forth. This is a typical progression of a biological theory. So our own research in Copenhagen has basically started as an orthodox empirical research. I was a young doctor at an institution where the famous adoption studies of schizophrenia have been conducted, which demonstrated that there is a familial, most likely genetic aggregation of schizophrenia. And I participated in the Copenhagen high-risk study, which was a study of 207 children of mothers who suffered with from schizophrenia. And these children were followed up from the age of 14, 15 up to the age of 46 or 47. And the whole idea was to look at which early premorbid characteristics predicted later schizophrenia. So I was lucky enough to become a part of this research program. And one thing which we found out was that in this prospective design, inadequate emotional rapport during the psychiatric interview at the age of 15 was something that predicted later schizophrenia spectrum disorder. It's perhaps nothing spectacular, but however, it was done for the first time in a prospective manner. And that research with these people, offspring of schizophrenic mother, was basically psychopathological research. And that's how the whole idea of disorder of subjectivity in schizophrenia was articulated in the very first place. I will mention here that by the end of the 1980s, I have met Dr. Pierre Beauvais of Lausanne, who became my very close personal friend and collaborator, and who was a source of a tremendous intellectual stimulation. I also collaborated with Louis Sass from Rutgers University in New Jersey. And he's also a friend, and we had a lot of discussions, a lot of fights, I would say. We also spent some time in southern France talking about the notion of self. It was a very pleasant time sitting in Saint-Tropez and talking about Ipseity. And finally, I will mention also my friend and colleague, Professor Dan Zahavi, currently Professor Dan Zahavi, who is a philosopher at the University of Copenhagen, and who was the person whom I approached to ask what to read at the moment when I was sort of confronted with the complaints of patients with schizophrenia. So Zahavi was very helpful in this respect. He referred me to a Danish philosopher who is not a phenomenologist, or was not a phenomenologist, Erik Clavon, who has published a few articles in English about Ipseity, but who wrote a masterful book about primary presence, about irreducibility of being me. So it was a very important book for me. And I, of course, also read phenomenologists. I have read phenomenologists before without properly understanding everything, but anyhow, what we noted in clinical work was that young patients who came with beginning schizophrenia, they could complain about voices or some negative symptoms in terms of lack of initiative or hypohedonia. But what was the main issue for those people was that they didn't feel themselves properly themselves. So you would have a whole range of complaints, such as, for instance, a patient would say, it would be wrong to say that I am lifting this bottle, but perhaps more appropriate to say there is an arm lifting this bottle. Okay? Another patient would say that I am everywhere and nowhere. It feels as if you imagine the sea with the water and plants and fishes. I am not a plant, I am not a fish, but I am a current of water which is everywhere without any borders and without any inherence. Other patients would say, like the patient of Blankenburg, in a similar way, would say that I am only a half. It would be something similar to what Pierre Janet described as sentiment d'incomplétude, where the patient does not feel sort of whole, so to say. The patients have a sort of lack of feeling of self-coincidence. I must immediately say that I'm using the term self-coincidence not in a philosophical sense, but in a sort of experiential sense. So the patient is always behind himself. This is, by the way, described by Bleuler in Dementia Praecox and Schizophrenia, where he describes ego disorders like a patient who says that I can never catch up with myself. And the majority of these patients have had these complaints for years, and many of them in late childhood or in early adolescence. I will come back to this issue in a moment. So what we started to do, well, we were a group of clinicians. You will probably notice if you have a look at my papers that we are a collective of clinicians who are all interested in phenomenology and collaborate together. And many of my co-authors are my former PhD students or current PhD students. So we started to sample the statements from the patients. So we had a sort of a base of descriptions, of self-descriptions from the patients. Then we started to look into the literature to see what has been published. Of course, nothing has been published in contemporary psychiatry, but things have been published before. So, for example, Brankenburg is a very good example. Tatoussian is also a very good example. He writes a lot about self in his Phénoménologie de Psychose. I got this chapter on autism translated into Danish because at the time I could not read French. And there were several other authors, such as Esnard, who has written about écho de pensée and stuff like that. We had also collaboration with the German group of Professor Huber, Klosterkötter, and Gross from Bonn, who worked with the so-called basic symptoms. Many of these items in the basic symptom list overlap what we call self-disorders. And finally, we were an international group because there was a Norwegian colleague, Paul Müller, who independently sort of stumbled upon self-disorders in beginning schizophrenia. And we invited a German colleague, Thilo Kircher, who was presumably better to quickly scan German literature for case examples than we were. So collectively, we published the EASE, the scale for the self-disorders, examination of anomalous self-experience, which was published in 2005. Thanks to the willingness of Professor Thomas Fuchs, who is the editor of Psychopathology, because it was very long and exceeded anything that was allowed in psychopathology. So as you see, many people contributed to this research, including Thomas, who is going to speak today as well. So what I want to say about the items of the EASE and this symptomatic aspects of self-disorders, that they are grouped into different categories or different items, but they all overlap each other. So they are not symptoms, properly speaking, in a sort of semiological sense. They are not independent symptoms, one from the other. And we have recently published a paper with a factor analytic examination of the data from several studies. So we had a sufficient number of subjects to make this statistical analysis. And in fact, this statistical analysis shows that the single item, that they reflect one underlying dimension of profoundly disturbed subjectivity. So the idea of a disorder of minimal self, or if you don't like to use this term, of the very basic structure of the articulation of our subjective life, is probably right to some degree. And what is this minimal self and this, or this first person perspective? Well, self-awareness is something which characterizes all conscious episodes. As Sartre says someplace, self-consciousness is the only mode possible for consciousness. Consciousness cannot avoid to be self-conscious. So this is a sort of an immediate experience. This is a passive experience. It is not instigated, it is not willed, and it is not a thematic experience. It is a non-objectifying experience. It is not like having a look at this plastic bottle. It is something which sort of pervades our experiencing without being an object of an experience. And it seems that this sort of very basic structure of first-person perspective, or minimal self, or cold self, is somehow unstable in schizophrenia. I think also, in distinction to Dan Zahavi, that the notion of minimal self must include some sort of affective sense of self-presence. It cannot be a purely formal notion, because a formal notion of self will never be conscious, so to say. A form by itself cannot be conscious. But this is a sort of detail on which we disagree. The other thing which I wish to emphasize, and which I said already alluded to, is that these disorders begin in childhood or adolescence. And since you are a Francophone audience, I can give you an example from my own clinical work without sort of disseminating privileged knowledge. I have had for many years a patient who was a child. It was a girl. She was a child of two parents with schizophrenia. And she was immediately removed from her biological parents, who were severely sick and could not care for a child. She was immediately removed and placed in a foster care, a family which finally adopted her. And it was a very good, very religious people, very good family. And the child was extremely difficult in her upbringing, in her development. She was very anxious. When she was 5 years old, she was given a dollhouse, a maison de poupée, as a present for Christmas or birthday, I don't remember. And she didn't want this dollhouse because her name was, let's say, Maria. She said, I would not be Maria any longer if I accept this dollhouse. So she said the sense of identity of Maria was very, very fragile. She managed to finish primary school. The first year of schooling, her mother was outside the class. At the age of 11, she got a psychotic episode, And I was contacted by a colleague, a child psychiatrist, who knew that I was involved in studying children of schizophrenic mothers. So I saw this patient, and I treated her with a very small doses of antipsychotic drug. And after 3 or 4 weeks, the psychotic episode disappeared. And she was referred to psychotherapy with her mother, and they went to psychotherapy until she was 18, once a week, to a very competent psychologist. And I saw her from time to time. And I have seen her until her age of 37. And from time to time, she needed a small antipsychotic medication for a couple of months or 3 months. But otherwise, she did quite well. She got an education, she's working, she has a boyfriend and stuff like that. So, but she had a lot of complaints of self-disorders from very early on. So the next issue which I want to bring up before talking about schizophrenia as a disease is the issue of double bookkeeping, which will also be addressed later today. So double bookkeeping, in French, double comptabilité, is a term introduced by Bleuler to designate the situation where the patient who is in a very severe psychotic state is nonetheless completely aware of what is going around him in the social environment. And Bleuler mentioned this phenomenon several times in his monograph on schizophrenia and also in his textbook on psychiatry. And we have sort of refocused on this issue in our clinical work on self-disorders. So I will quote here Professor Eileen Sachs, who is an American suffering from schizophrenia, and she has written a very known book in the Anglophone world, which is called The Center Cannot Hold. It is her memoir of schizophrenia. It is a very important book because it has a little bit shaken the Anglophone model of a sort of brain disease which leads to some sort of rambling confusion in all cases. And she says, my life is like to have 2 trains on 2 separate tracks. There is a track of my social world, of my professional duties, family relations, books, and the other track of my private mental life, which is populated by strange and frightening phenomena. So what we have done a systematic empirical study of this phenomenon of double bookkeeping. And in fact, the vast majority of patients with schizophrenia do have this sort of double ontological orientation. On the one hand, they are attuned to our social reality. They know that the table is the table. On the other hand, they have a private realm, which is sort of a modification of the immanent sphere, where there is articulation of psychotic symptoms, which also gives the patient a sense to a breakthrough to some form of transcendence. So most patients say that they have a deeper insight into true reality compared to ordinary people, or they have contact with God or contact with some astral dimension or something like that. And these two perspectives are incommensurable. And for this reason, the patient does not see them as contradictory. So the patient lives very well among other people, but still have his psychotic world present. And an important thing for psychiatrists to realize that this private reality has for the patient a truth value. It is valid, it is relevant, and you cannot persuade the patient to the contrary. So it would correspond, for example, if I said that I have a toothache, mal aux dents, that you said to me, no, you don't have mal aux dents. It's a nonsense to try to persuade somebody who is suffering from pain that he is not in pain. In the same way, you cannot persuade the patient with double bookkeeping that his private sphere is abnormal or sick. And that leads to the next issue, is that the notion of insight into illness, which in a medical model is defined as an awareness that I have an illness, I have to avoid certain provoking agents, I have to take medications. That kind of insight presupposes an experiential distance between the subject and the illness as an object. In case of schizophrenia, you cannot have this possibility for structural reasons, because the psychotic phenomena articulate themselves in the immanence of selfhood. So what the patients say about their own condition is that they feel best when there is a balance between their private reality and the social reality. And when the private reality sort of invades social reality and there is complete psychotic breakdown, then of course the patient is very sick, is typically admitted to the hospital. So this is a cardinal aspect of schizophrenia, because it questions the whole picture of schizophrenia of remissions and relapses. Because even in remissions, the patient lives in his psychotic world in a way that does not interfere with his functioning and relations to others. I will mention a vignette where we had a training interview for some nurses, and the patient was a patient with chronic schizophrenia on a depot treatment, and she was asymptomatic for several years, and she was talking about her psychotic episode, and her psychotic episode started with a feeling that her telephone was bugged. And from there was a sort of a cascade of psychotic symptoms. She was admitted and so forth. But it was all gone after medication, and she was fine. And the interview stopped. The nurse who interviewed stopped there. And I was the supervisor. So I asked the patient, but Mrs. Hansen, what I do not understand is, why was your telephone bugged in the very first place? And she said to me, you know what? I am asking this question to myself to this day, okay? So what we can see here is that the original psychotic experience is completely intact in her consciousness. It does not play any role in her relations to others, but it is not away, so to say. So finally, I will summarize what can be so said today about schizophrenia. Well, one thing which we can say is that we don't know what causes schizophrenia. We know that there is a genetic factor, that at the moment there are perhaps 300 polygenes that are involved in schizophrenia, which cannot translate into anything useful from the medical point of view or any other point of view. The other thing we can say about schizophrenia is that there is no real insight into illness as in the somatic disorders. So the doctors and the patients do not agree about the nature of the illness of the patient. A third thing which can be said is that the whole issue of the onset, the beginning of schizophrenia, is conceptually completely unclear. So this sort of early detection research, according to me, is based on some false assumptions and wrong epistemology. Because most patients, in fact, if we call it illness, they have been ill since they have been children. The third issue, it is an illness where the subjectivity of the patient is different, is articulated in a way that leads to a lot of phenomena which are painful for the patient and may lead to severe psychotic behavior. And the last thing which we also know about schizophrenia, that schizophrenia is associated with increased creativity among the biological relatives of schizophrenia patients. So in sum, I think that the picture of schizophrenia, which we have from a sort of more phenomenologically oriented clinical studies and epidemiological studies, is in a certain way, sort of dissonant from the notion of a brain disease with some sort of focal damage or network damage. And I think it needs rethinking in these terms for us in order to progress what kind of treatment we can offer to people with schizophrenia. And one thing which I forgot to mention is that the course of schizophrenia is extremely variable. And there is nothing that indicates that these are different diseases. Although many people say it very frequently, that it is an ensemble of different diseases, but there are no data on it. The course is very variable. There are people who are university professors and who fulfill criteria for schizophrenia. I have colleagues who are psychiatrists who do it also. So it's a very strange notion of a disease. So I think I will stop here. Thank you very much.